tuned into CBC radio. And as often happens, I had tuned in right in the middle of an interview, but I very quickly wished that I had heard the entire conversation, because as I listened to Dr. Amy Wendell that day, I kept hearing things that just resonated so nicely with the kinds of things that we talk about here at the Attachment Network. And, you know, particularly about how important the role of connection is when we're talking about, you know, postnatal mental health struggles. And she just had such a compassionate, you know, way of talking about this issue, and, you know, was talking about it, you know, so kindly and seemed so approachable that, you know, I just thought, man, she would be perfect for one of our lunch and learns. So I looked her up and sent her an email, and she very graciously agreed to join us here today to present on that topic, because I knew that was something that a lot of you would be interested in. And I'm just super excited that she's here. I'm really happy she agreed to join us, but I don't want to take up any more of our time today, because that's very short. And so if any of you are interested in learning more about Dr. Wendell, I'm going to invite you to check out her bio on our website. And with that, I'm just very pleased to introduce you all to Dr. Amy Wendell. Welcome.
Hi, thank you, Leslie. Thank you so much for having me. This is kind of surreal. Like, I don't know, I'm 46 years old and, you know, have my doctorate in psychology and all that, but like, still, I'm kind of like, really, people want to hear me talk about stuff? Like, I don't know, a little bit of an imposter syndrome happening here, but it's nice to be welcomed by you and for me to feel connected to other providers and clinicians out there. As maybe Leslie mentioned, I practice in Russell, Manitoba. So I'm about 4 hours west of Winnipeg. And I think that I'm the only psychologist in like within maybe like an hour to 2 hour radius. So I do feel very kind of isolated in a lot of ways. So it's really nice to see faces and get to know a little bit more about the landscape out there. I am from Kentucky originally, and I've been here in Manitoba for about 6 years. I've been in private practice for a little over 3 years now. And prior to coming here, I worked mostly in student counseling center settings. So I was working with university students. And once I moved here, I had to revamp that plan. And I had always been interested in private practice. My dad is a psychologist also down in Kentucky, and has operated a private practice for a long time. So I kind of grew up watching him, and it's been a real learning curve being here and operating my own business, and serving, a really big population and a lot of different needs. So I know I'm here to talk about perinatal and postpartum depression and mental health issues. That's one kind of subset of the struggles that I see here in my practice. So I'm curious too, though, to hear from you all about what it is that kind of how this issue shows up in your line of work. Hopefully I can respond to what you're looking to get out of today's presentation, but I really do like interaction. So I would love it for people to pipe in and ask questions or share their thoughts as we go. But maybe I would like to turn it over to anybody who wants to be brave and speak up and say a little bit about like how these issues show up in your line of work and what you're hoping to get out of today. So tag, somebody's at.
Valeria's got her hand up. You could just unmute Valeria.
Yeah, okay, thank you. You know what, it's funny, we were just talking this morning about a case here. I'm Valeria from Healthy Start. We run groups for pregnant families and families with babies up to 1 year of age. And we were talking this morning about a case we have. We suspect that there is postpartum depression or something very similar. and perhaps more complicated, but one big struggle is to access to services right away. We have a nurse that is working closely trying to get, to talk to this participant. But yeah, then once we have a closer kind of diagnosis or something like it, to access to services, it's hard without having to wait in a waiting list for a couple of months.
Yeah, so counseling services, is that what you're talking about, Valeria?
Yeah, therapy, or even the whole package, right?
Yes.
A doctor, a psychiatrist, and counseling as well. Thank you.
Yeah, I feel that struggle out here as well. So it's happening in rural communities too. Yeah.
Tracy put in the chat that public health nurses, of course, see prenatal and postpartum families and support families with PPD accessing services. It's a reminder.
Okay, so struggling to access services and have availability. Are people pretty knowledgeable about what's out there? Is that something that you're aware of? It's just the wait lists are really, really long.
I think, Amy, one of the things that I found as a young mom, and this is a few decades ago now, was the depression. Calling it postpartum depression almost removed the possibility of looking at women that were feeling very anxious and heightened. Depression always seems very subdued and flat.
Right.
And the opposite, of course, was the anxious response, where people were activated. And I see you have a couple of slides, so I'm not going to give it away, but I was appreciating when I looked at your PowerPoint how you've included that other spectrum where we're sort of controlling everything and busy and can't do enough. And there's this relentlessness about it.
Right. And I think there's been a shift in the terminology more recently too, to include perinatal, meaning kind of before conception, at conception, during pregnancy, and post, to include both depression and anxiety, that it's kind of all within that umbrella. And we'll talk about how it often shows that both of those types of symptoms can be present in a person as well. Okay. Well, does anybody else have anything they want to ask or kind of put out there that they're looking to get out of today before I get going? Oh. Okay, and I will say I did clear this with Leslie and Joanne. I have to wrap up at 5 till because I have a kiddo who's performing in the festival. He's reciting a poem and it's close by and I can run over there. It's 2 blocks away, but I hope to get there by 1:10. So I asked if we could wrap up at 12:55. So I will do my best to keep an eye on the time and move us along. But I hope that we can also have some back and forth conversation too. Okay, so just getting into terminology at the start to talk about different diagnoses that we give and what these terms mean. So I kind of touched on this, that perinatal mental health can describe lots of different periods surrounding pregnancy. So we may have issues that happen before conception with struggles to conceive. There also might be things that come up during pregnancy, a lot of worries and concerns. Sometimes we learn that our baby, I think about my sister who went for her 20-week ultrasound and learned that their baby had a pretty significant heart issue. And so that can kick up a lot of anxieties. And then the delivery experience can be traumatic and there can be a lot of loss of control that happens within the delivery experience, and then postpartum as well. We also don't want to forget about pregnancy loss and how that is a whole kind of another category of that involves a lot of grief and adjustment as well. So postpartum depression, I did a quick search. I didn't really cite my where I got this, but it generally affects about 23% of Canadian women. And it's a broad term that can also capture postpartum anxiety, OCD, panic disorder, PTSD, and postpartum psychosis. And so as I say that, I'm just aware of that can be such a range of presentation and symptoms. And I think about all of this following kind of on a continuum where we may have, people refer to the baby blues, which can come from just all of the natural adjustments that are happening. Even when we have ideal circumstances, there's so much that we are adjusting to. I made a quick list: sleep deprivation, hormone fluctuations, demands on breastfeeding, constant touch and attending to the needs of baby, loss of identity, loss of independence, strain on relationship with your partner, if you have a partner, grief regarding the life that you had before baby came. Even if you are excited to have your baby, there's so much that you're grieving with the changes that are happening. You may have other children, and so there may be grief about the change in that attachment bond and your availability to your other children. Changes in your body and how you relate to your body and your sense of sexuality. Dissonance between the reality of your experience and society's expectations. And we may have feelings of low self-worth, feelings of failure. So that's just a spur of the moment list that I came up with to describe all of the adjustments that come even when we have pretty ideal circumstances. And then looking at that list of different diagnoses, there can be really severe issues to pay attention to. Back to postpartum psychosis, we can think about that. I don't know if some of you have interacted with clients and patients and women who have experienced postpartum psychosis. That can be pretty scary. I'm just curious, does anybody have any experience with that? It's hard to ask these questions in a big group. I recognize that. Okay, so I'll just say, postpartum psychosis is a whole different kind of beast is the wrong word for it, but it's a really scary situation for women to experience. And I can think of my husband, who's also a psychologist, used to do mental inquest warrants in Kentucky. And I was talking to him about this presentation and how it's really, it can be easy for us to brush things off and and hope that things aren't so severe. But when it comes to things like postpartum psychosis, these are things that we really need to take seriously. My husband had done an evaluation on a woman whose family had real concerns for her, and they said that she's not herself and she's not attaching to the baby, and she was pretty flat affect, just really shut down. And my husband had evaluated her, and she did go to the hospital for 3 days and was held there for 3 days, and then she was released. And she had said, I don't want to be here anymore. I can't do this. And after her release from the hospital, she died by suicide. And so I say this because it really can be very significant and severe. And so these are things to not take lightly. And we'll talk about the questions that we want to ask to evaluate and assess for level of severity. Okay.
Amy, I'm just going to interrupt. There's a few people that are putting things in the chat to you as well. So.
Thank you. Okay. I personally had depression with my first child. My good friend that went to high school committed suicide. Wow. Okay. Yeah, I'm just looking through these. It can be very real and not something to be taken lightly. And I think, I don't know about you guys, but those are scary questions to ask. And I think the thing that I want to get across, and we'll get to this a little bit later in the slide, is to look at your own fears in asking those questions and making those assessments. and to work on that fear for yourself before you're in this line of work or you're kind of confronted with that. Or if you find yourself being held back by fear, being honest with yourself about that and getting support with other colleagues. And, just, it's really important to reach out yourself as the helper if you're finding yourself held back in moving towards these issues. I hope that makes sense. Okay, so let's talk about risk factors. So first of all, before we talk about that, I think about the stress diathesis model. And I don't know if everybody's heard of that term, but it's essentially this idea that we all have factors that can contribute to kind of a predisposition towards mental illness. So if, for instance, we have a family history, say like aunts and uncles who suffer from depression or anxiety, or if also we have seen modeled to us behaviors like suicide as ways to cope, that increases the likelihood for suicide and other mental health issues. So thinking about, kind of the factors that contribute to our predisposition towards mental health, and then we combine that with stressors that occur in our environment. And so if we have a genetic predisposition plus stress, the likelihood of the onset of a mental health kind of episode or issue is more likely. So things to keep in mind are familial and personal mental health issues. Does the person have a history themselves of a depressive episode or of anxiety? Do they have a trauma history? What does their relationship with their partner look like if they have a partner? What do just their relationships in general look like? What does their support look like? And that could be not just social support, but it could be financial support, spiritual, physical health, things like that. Was this pregnancy planned or unplanned? How does the woman feel about the pregnancy? Has this person experienced pregnancy loss before? Have there been infertility issues? And has there been a prior trauma with birthing? So these are all factors that would increase the likelihood of some mental health issues. Okay, next. Okay, and so what we want to do is assess those risk factors. So to ask questions and to better understand, kind of what we're working with. Asking if there's any sort of history of depression, anxiety, OCD, etc. And understanding, when did this begin? What's kind of the baseline for this person? When did you first start seeing symptoms? How long have those been present? To what degree are these symptoms impacting daily functioning? And are these symptoms impacting multiple areas or just one area? So those are all considerations when we're looking at kind of the severity. And we also want to look at attachment concerns for mother and baby. And I know that I'm speaking to a lot of people who are interested in attachment. So I don't probably need to educate you about secure versus anxious, avoidant, and disorganized. But as you know, the mother's mental health and wellness really, really affects attachment. So is she able to be present? Is she regulated? Is she attuned to her baby's needs? Is she able to be responsive? And all of these are very important for the child's well-being as well as the mother's well-being. And then just assessing and asking what kind of support the mother is connected to. So wondering, like, does she have a relationship with church community, like other mothers who are new mothers? What are her family relationships looking like? Okay, so those are some areas to assess. And then I'm really interested personally in trauma, and I think a lot about how oftentimes we overlook that trauma can be present in the birthing experience, or just throughout perinatal, kind of the whole spectrum. And I think it's important first to understand what trauma is. And I'm just wondering, is everybody pretty familiar with trauma? And kind of, yeah. Okay. So, right. So we know that when trauma occurs, it's basically kind of whether or not it is kind of encoded as trauma depends on our nervous system and our response to the situation. So when, the hand-brain model here, when our amygdala senses danger, it sounds the alarm, and the prefrontal cortex goes offline and is not available. And when that happens, all of the information that is coming into the system gets kind of loaded onto a snapshot. And rather than going nicely from short-term memory into long-term memory and getting filed away, instead, all of that information kind of lives on in our system. So the thoughts that we're having at the time, the emotions that we're experiencing, and also our physical sensations kind of get loaded onto that snapshot, and it's kind of living on in our system, waiting to be reactivated when similar thoughts or feelings or sensations come up. That's all pretty familiar to you guys? Okay, so yeah, I was just kind of thinking about this particular time in life, and some of the thoughts that could be present would be like, I'm not good enough, I'm defective, I did something wrong, I'm in danger, etc. So I'm just thinking about birthing experiences, and I wonder if anybody has any stories that come to mind with working with women where they did have these types and do maybe have these types of thoughts coming up. I mean, I will say, I can just think about my own first birth experience with my son Elijah, and I was able to thankfully have a vaginal birth, but I really wanted to go without medication and, kind of keep it as natural as possible. And my cervix just kind of quit dilating at a certain point, and I started experiencing the pain differently. And I then I chose to get an epidural, and, kind of a cascade effect happened with other types of interventions. And even though, Elijah was born very healthily and I was healthy afterwards, I had a lot of kind of personal, like, beating myself up for not following the birth plan that I had in my mind. And thoughts of, that it really impacted my sense of self-worth as a mother. And I consider myself to be relatively well-adjusted, and I struggled with all of those things. And so that's an example of, kind of really lower level, but I know I experienced that myself. And I see from Leslie, my daughter-in-law had an extremely traumatic birthing experience with my first grandchild. Yeah. Do you want to say anything more? Somebody just spoke. I'm sorry.
Yeah, no, I was just saying, as you were asking, Leslie, somebody's got their hand up. They're listed on as iPhone 26, but I have a feeling their mother named them something different than that. But please unmute yourself and speak.
Hi, my name is Shallon, not iPhone 26, but I'm a public health nurse in Kenora, and I just had a very similar experience with traumatic birth with my first one, and then followed by breastfeeding issues. And as a nurse, I struggled with the fact that I was helping other people breastfeed, but couldn't do it myself. And I felt like such a failure. I compared myself to everybody else around me and found myself in a pretty deep, dark place for a bit there. So I think kind of that breastfeeding, something that's supposed to be so natural, like along with childbirth, but we really push breastfeeding, it's such a wonderful thing, but we have to remember sometimes, like, I tried everything to breastfeed. I was exhausting myself to a point of probably stressing my body out too much. So I think just keeping in mind too, that the after effects of motherhood too, or if you don't feel connected. I know with my second one too, I had bleeding in my pregnancy and had a hard time connecting with the pregnancy because I was scared I was going to lose him. And then when he came out, I always just had this irrational fear that I was going to lose him. And he's my wild child. So I still in the back of my mind worry, but yeah, like connecting with those things too, I found it difficult. And as a health professional too, scared to reach out because I felt like then I was also failing. So it was hard for a while until I finally talked to somebody.
Yeah. Thank you so much for sharing that. And it's so interesting that we as healthcare providers, and, you know, we're very emotionally aware. It's amazing that we can encourage other people and see with such compassion that it is not a reflection of their self-worth, but we can hold ourselves to such different standards. And I can identify with that too. Yeah, it's really complicated. And as you share that story, I just am so aware of all of the nuance. And, you know, everybody's individual experience is so unique and so valid and important. And I think the thing that I take away from that is, like, looking back with hindsight, I just wish that I had spoken up more and shared and like reached out and talked about these struggles, because I know as soon as I would share that, I'm sure other friends could identify, right? Like, so we're so not alone. But back to self-compassion, you know, when we're experiencing difficult times, it's our tendency to pull back and isolate. And it's like the opposite of what we need. We need connection. Yeah, thank you for sharing that. And Leslie, you were saying that your daughter-in-law had a traumatic birth experience.
Yeah, and also that I completely relate to the breastfeeding story. So yeah, I'm with you, sister. That was a whole other, wow, am I ever a failure? Because this is supposed to be a piece of cake, right?
Yes.
So I certainly relate to that. But the interesting thing with my daughter-in-law is that I think it took a while before I really understood the whole story and how, so it, you know, kind of kept coming out and coming out. And it was a long time, you know, it was a few months after he was born that I felt like I'd heard that whole story about how traumatic that had been. And I think it was just sort of this aftershock, you know, for months later about, you know, how, wow, that was really awful.
Yeah. And Leslie, what do you think contributed to it taking a while for the story to come out?
I think it was almost, I think in some ways she was almost in a little bit of a state of shock or putting it away somewhere for a while. That's just sort of my guess, right?
Yeah. I mean, I think that's really common for a lot of reasons. I mean, you think about the logistics of it. You have this baby who's screaming and needing attention and feeding and changing and, you know, all of the needs. And so there's just not the bandwidth and capacity to,
that's a good way to put it.
Yeah.
That's a
pull back.
Yep. Very good way to put it. I'm already full.
Yeah.
Maybe, and I'm doing that. So I'll deal with that stuff someday.
Yeah. And sometimes you just need time and perspective to be able to see it, and the space and a safe relationship where somebody's asking those questions and kind of leading and facilitating you to, like, you know, kind of go there. Thank you. Okay. So just seeing if anybody else has their hand up or chats, and no other chats that I should respond to. Okay. Yeah. Okay. So we've talked a little bit about what's happening in our nervous system when trauma is occurring. So negative cognitions we spoke of, oftentimes emotions that may be associated would be shame, guilt, sadness, powerlessness, helplessness. And I think about, wow, shame, that emotion can really, really hang us up. You know, and oftentimes shame is the secondary emotion to the primary emotion, maybe sadness or some other vulnerable feeling, but then quickly it can present itself as shame. And that gets really confusing to be able to get underneath the shame to those primary emotions that ideally need to be addressed and understood. And I think too about how, again, shame is one of those feelings that, you know, if you kind of were to picture what your body does in shame, I know for me, like I'm hunched over, I'm looking down, I'm not making eye contact, I feel constricted, the opposite of like reaching out and open-hearted, you know, able to receive connection. We're not in that state when we're in a shame state. So those emotions can really wreak havoc for us. And I think about with, well, either anxiety and depression, you know, when we're in that kind of hyper arousal state, we're not in a place where we can really take in new information and have perspective. And when we're in that shut down depressive state, we are also feeling hopeless and helpless and not really able to take in information. So it makes it really hard. Those feelings can complicate things. And then common physical sensations. I've just, in working with a lot of trauma, these are oftentimes where we experience it. We may feel pressure and constriction in our chest, might have sensations in our throat. I think about like Reiki sessions and the throat chakra. And, you know, I'm thinking about when you're delivering your baby, and if things feel out of your control and you don't have the ability to speak out, it can really show up in your throat. Also in our gut, we may have numbness or tingling in extremities and heart palpitations. So it really can present in so many different ways. Okay, next slide. I think we've kind of touched onto this, how trauma gets processed differently. And then when other things happen in the present day that remind us of those thoughts or those emotions or those physical sensations, it's kind of like we're back in it and our body is believing that we are in danger. So that would be more like kind of PTSD stuff. Okay, and then just the last point here, oftentimes trauma can get overlooked and dismissed. And I think we're about to get to the Brene Brown thing, maybe, but it's so common that we want to focus on the positive because we are uncomfortable sitting in pain, basically, and joining somebody in that. And so it's so common that people would make comments like, you know, but why are you sad? You've got this beautiful baby. Let's focus on that. And I think that's what the CBC radio clip was about. There was a woman, right, who was in Manitoba who had sought help from her general practitioner, and that practitioner's response was really unintentionally harmful, but was very dismissive. Okay, we can go to the next slide. So maybe everybody has seen this clip. I don't know, but I think it's not, it wouldn't hurt us to watch it again. So just looking at Brene Brown's description of the difference between empathy versus sympathy. And Joanne's going to do that for us, I think. Hopefully it works.
Oh. You know what? It didn't.
Oh, shoot.
No, it didn't load, but that's okay. We can do it.
Okay.
Sorry.
Has everybody seen this? Like I can see 4 different faces. Okay, some people haven't. So I used to show this in my university counseling center to the staff who worked at the university.
This should work.
So what is empathy, and why is it very different than sympathy? Empathy fuels connection. Sympathy drives disconnection. Empathy, it's very interesting. Teresa Wiseman is a nursing scholar who studied professions very diverse professions where empathy is relevant, and came up with 4 qualities of empathy. Perspective taking, the ability to take the perspective of another person or recognize their perspective as their truth. Staying out of judgment, not easy when you enjoy it as much as most of us do. Recognizing emotion in other people and then communicating that. Empathy is feeling with people. And to me, I always think of empathy as this kind of sacred space when someone's kind of in a deep hole and they shout out from the bottom and they say, I'm stuck, it's dark, I'm overwhelmed. And then we look and we say, hey, you climb down. I know what it's like down here, and you're not alone. Sympathy is, ooh, it's bad, no, you want a sandwich? Empathy is a choice, and it's a vulnerable choice, because in order to connect with you, I have to connect with something in myself that knows that feeling. Rarely, if ever, does an empathic response begin with at least. I had a, yeah. And we do it all the time. Because you know what? Someone just shared something with us that's incredibly painful, and we're trying to silver lining it. I don't think that's a verb, but I'm using it as one. We're trying to put the silver lining around it. So I had a miscarriage. Oh, at least you know you can get pregnant. I think my marriage is falling apart. At least you have a marriage. John's getting kicked out of school. At least Sarah is an A student. But one of the things we do sometimes in the face of very difficult conversations is we try to make things better. If I share something with you that's very difficult, I'd rather you say, I don't even know what to say right now, I'm just so glad you told me. Because the truth is, rarely can a response make something better. What makes something better is connection.
Such a good reminder. That gets me a little bit teary-eyed. And yeah, I think about the work that I do and that you all do with women, and sometimes just reminding ourselves that it's really comes down to the simplicity of connection and being with. You know, I can get really caught up in like thinking about what interventions do I need to use and wanting to fix. But at the end of the day, that being with and feeling understood is transformative. I have a quote from Carl Rogers up here. I'm going to read it. I didn't plan to say this, but I wrote this quote out at the beginning of like when I first started working with clients, because it resonated with me so much. But he says, I realized there's something I do before I begin a session. I let myself know that I am enough. There is no pain that this person can share with me that I cannot understand, because I too am a human being. There is no loneliness, no doubt, no darkness that I do not also share. She does not need to be ashamed or alone with whatever she carries. This is what will allow her to discover her truth and begin to heal. I can accompany her and be with her as she remembers who she is. I am enough because I too am a human being. So I love that. And this little note card has been with me for like 20 years, and I just kind of tape it up next to my desk in whatever office I'm in. And sometimes when I'm about to go into a session with somebody who I know it's going to be heavy, I read that to myself, and it's a really nice reminder. And you're welcome, Valerie, for sharing. I saw your note. Okay, so yeah, and that just, it makes me think too about, is anybody aware of, yes, I can share that with you later, that quote. Have people heard of Tara Brach and the rain meditation? Is that something that's familiar to people or no? That might be something else that I would share. So Tara Brach is really associated with mindfulness. I think she works a lot with John Kabat-Zinn. And on YouTube, you can type in Tara, T-A-R-A, and then RAIN, R-A-I-N. And it basically, it's an acronym that stands for, it's a guide to ways of being with an emotional experience. So it stands for, R is recognize. So pull back and recognize I'm having an emotional experience. A is allow it to be here rather than pushing away, which is our tendency with pain. We want to get rid of it, so we push away, or sometimes we really attach to it. And so allow is kind of taking this perspective of mindfulness and allowing it to be present. And then I is investigate. So it's asking yourself, where am I feeling this in my body? What is this sensation trying to tell me? If it could speak, what would it say? What am I believing right now? Kind of investigate and be a curious observer. And then N stands for nurture, which really overlaps a lot with self-compassion. So as you're being present with the emotional experience, bring nurturing to yourself. And so she guides you through that. And I think about how clients can do that for themselves with this guided meditation, but also how we as practitioners can help guide that in our conversation. So we're wanting to recognize this person is having this experience. Allow it to be here. Don't try to change it. Just be with it and take an accepting stance and a non-judgmental stance. And the I is ask the questions. Don't be afraid to directly ask things like, are you having thoughts of killing yourself? Are you having thoughts of harming your baby? Because when we ask those questions, we are teaching them that we can handle the truth, right? And so in being able to ask the questions directly, we're saying, I can handle this and I can support you. Yeah, suicidal ideation. Are you having thoughts about suicide? And then the nurture, like you bringing nurturing to your client as well, bringing compassion. And you can do that with making good eye contact, with just, facial expressions, leaning in, kind of uncrossing your legs, uncrossing your arms, just this open stance that you can take, and using, a caring tone in your voice. All of those things convey compassion. And then we want to normalize, because I think that, we've talked some about this, but when we're in this place of shame, we tend to pull back and feel also like nobody understands and nobody can identify with this, and that we feel very much alone. And so we want to start to normalize and provide psychoeducation about why this is possibly going on for you. And we want to be very non-judgmental and non-accusatory, and help connect the person with resources. I guess one other thought I just want to share, or I want to encourage you to think about a time in your life where you've been in emotional pain, and what kind of responses were not helpful versus what was helpful when you think about like being with another person in your pain. And would anybody like to share that? Get over it. I see that coming up in the chat. That was not helpful, right? Okay. Yes, I agree. I thought you were saying that was helpful, and I was like, wow, I operate really differently. Yeah, I hear a lot of the get over it, like from my clients and what they've grown up with. Suck it up, like just get on with it, get out there and work, get back on the ice, get over it. I hear a lot of, and I see how that causes a lot of problems. What has been helpful? I'll share with you, I've been in my own therapy a few different times, and it's always, it always surprises me how just having space to feel my feelings, like to not have my psychologist or therapist step in and try to change it or move me away from it or move me forward, but just giving me the space to be with my feelings and experience them and being witnessed in it. Like that in itself is so powerful, right? Yeah. I see meeting someone where they are at, listening to my words and feelings, validation. Yeah. Yeah, these are not super complicated things. They can be complicated to give because of our own discomfort, but at the end of the day, it's pretty basic what really feels the most meaningful and healing. Yeah, just being. Okay. Okay, so wow, I feel it's like how do you address everything in 50 minutes, right? But general recommendations on that next slide. Empower the woman to talk about her feelings and experiences with trusted and safe people. Be cognizant of what you are consuming, like what the patient is consuming in terms of social media. Like I see a lot of clients who are, spending hours on TikTok and things like that. And I think about what that does to our nervous system and the comparison and all of that kind of stuff. So what does their daily life look like in terms of what they're consuming and who they are relating to? So I think about empowering them to check in with themselves, like how do I feel when I'm relating to my partner? How do I feel when I'm relating to my mother-in-law? Like to this friend versus that friend, and learning to use that as information to guide them about like who needs to be in their innermost circle. I think about back to Brene Brown, she talks about who deserves to hear your shame story, and that people need to earn that, that you're not gonna, there are kind of different levels of sharing, and to help your clients check in with themselves about like, what are the qualities that I'm looking for of who needs to be in my innermost circle right now. And when people are in crisis or struggling with mental health issues, oftentimes it's really helpful to just narrow the focus to the most basic of needs and meeting those. And then, yes, I said you or other supports may need to get directive depending on the level of functioning. So focusing on short-term manageable steps and tending to basic needs. I don't know about you guys, but when I'm dealing with a crisis, I just naturally go into getting more directive and narrowing that focus. And I think that that's what's helpful in that situation. And then you can think about, I always think about Maslow's hierarchy of needs. And, when somebody is in a crisis, it's really about kind of going to the base level and kind of working your way up. But sometimes I draw that out for clients and talk about what each level represents and how they can tend to those needs. And then bringing loved ones in to provide some education to them, because oftentimes, if a woman is in a state where she's very depressed or highly anxious, she's not necessarily able to take in the information. So we want to educate the loved ones about what's happening for her, and make sure that they're not shaming the person, and that they may need to kind of do for in that period if the person themselves isn't able to meet their needs. Okay, and then the last, so these are some resources that were given to me by our public health nurse in Russell, and you may be aware of some of these or all of these, and you also may have resources to share with me. I'm learning too about what's available, so I'm curious if there are resources that are not listed here that would be helpful to share. if anybody else has any resources. Or thoughts, just general thoughts, questions, discussion points. We're close to time. But I'm just wondering, like, kind of to be continued, like what you hope to keep thinking about, what kind of conversations you think are going to be important to continue having in this group. Private counseling, is that what I saw?
Mm-hmm.
Yeah, private counseling and therapists.
I think, when we think about resources, we tend to think about more structured things or more formal things. And I think some of what we've been hearing today and reminded of is just how powerful being with is. And anybody can do that. A friend can
Yes.
do it, a mother-in-law, an auntie can do that. Can be with someone who's sharing something or who's feeling something. And, we know that some people are better at it than others, right? I mean, some
Yeah.
people just are more settled themselves or more regulated, but I think it's just nice to be reminded of the fact that, everybody can provide that for someone who's in their network, who's struggling.
That's a
That was
really good point.
Really nice to hear.
Yeah, thank you for that. And that is within our power, and yeah, how powerful that is. And I will send that quote from Carl Rogers, and you could share that with the group.
That was great. Yeah, that was beautiful.
Yeah.
Maybe what we'll do is just for people, if they want to look back at this or share it with colleagues, that we'll have the recording up on the podcast tab of our attachmentnetwork.ca website, probably by Monday or Tuesday, and we can add in the extra little things that Amy was going to send. We can kind of tuck it in there as well, so it'll all be in one spot.
Yeah, thank you. I feel whenever I'm part of these or do these things, I'm aware of, like, it feels like we're just kind of scratching the surface here.
Yeah.
But it's a good conversation to have, and I appreciate you for having me here.
Well, I think there was a lot in 50 minutes, really. I think there were a lot of really practical things, for anybody here who's, in whatever way encounters someone who's struggling. I think there's some real good, solid advice in terms of how do I approach this? Where do I start? Where do I go? So I think in 50 minutes, I think there was a lot there that's see some people nodding that's going to be useful for people. So
yeah, and I think too about, like, some training that I did called QPR, which was about suicide prevention, and it stands for question, persuade, refer. And it's that idea that it's not your job to fix it all, but it is what our job is to be brave enough to ask the questions that are important and kind of more thoroughly assess. And then if it feels outside of your scope of practice, to refer, and kind of with the bond that you've created, with the compassion that you've established and safety, to kind of hold the hand of the person to get them connected to the appropriate referrals. Yeah.
I'm seeing lots of comments in the chat here. I think everybody really enjoyed this hour. I know I did. I know you've got to run, so enjoy the performance.
Festival. Thank you.
Thank you so much for making time for this. This was great.
Thank you. And if I'm in Winnipeg,